We come to these newer generation formulas. We start with the Barrett's formula. The Barrett's suit includes 3 formulas: the Barrett's Universal 2, the Barrett's Toric for toric lenses, and Barrett's True K for non-toric patients with laser vision correction. Barrett's suit is incorporated in IOL Master 700. I have no financial interest. It also has, the formula is also available online. It is a Virgins-based formula. It is based on the eye model in which the anterior chamber depth is related to the axial length and the keratometry. It is applicable, as I already spoke, it is applicable for all axial lengths. The requirement for a Barrett's formula is the axial length, keratometry, and lens factor. So the Barrett's suit includes the lens factor. Lens factor is calculated out of SRKT, the A constant. Design factor is IOL specific, which influences the IOL calculations. So without the design factor, white to white, anterior chamber depth, and lens thickness, the results are possible, but the measurements are more precise if these measurements are also included in the Barrett's calculation. The Barrett's toric formula is also comes from Universal 2 formula. It calculates the posterior corneal astigmatism, and it is quite accurate, comparable to other toric calculators. There is a Barrett True K formula for post-laser vision correction eyes. It offers a double K adjustment to overcome the inaccuracy in the central K readings in patients who have undergone prior refractive surgery. In IOL Master 700, there is a measurement known as total keratometry. Again, I have no financial interest. With this measurement, we are able to derive 2 more formulas in the Barrett suit, that is the Barrett's TK Universal 2 and Barrett's TK Toric, which is even more accurate for laser vision correction eyes. The second formula we move to is the Hill RBF formula. It uses artificial intelligence and regression analysis. Due to pattern recognition, and algorithm may be able to account for undefined factors, which is not possible in formulas based on Virgins and ray tracing. But the disadvantage is that because it's based on empirical data, the accuracy is limited by the type of data and the eye characteristic from which it is involved. But as the database increases, this disadvantage decreases further. So we are in the version 3 of Hill RBF, and the out of bounds has decreased drastically as the database has increased. The third formula is the Superlada's formula. It incorporates many existing formulas into a single equation. Variables like anterior chamber depth, axial length, keratometry, A constant, and gender. Lens thickness and central corneal thickness are optional characteristics. It has a toric as well as a formula for keratoconic eyes. A number of studies have come up with Kane's formula. Internationally, this study has shown that Kane's formula is more accurate than the other newer generation and the 3rd and 4th generation formula by using just 3 variables, that's the axial length, K value, and the ACD. But when we saw the Kane formula in Indian eyes, the result was not as good as the Barrett's and SRKT formula. Another new formula that has developed is the Emmetropia Verifying Optical Formula, developed by Dr. Tunyo in 2016, and the newer version has come in 2019. It is based on the theory of emmetropization. It is a thick lens Virgins formula. The calculator is available online. There is another formula, the Olsen C formula. It was included in 4th generation formula, but a newer generation, a newer variation in this formula is predicting the effective lens position using the concept of C constant. So C constant is a fraction of the lens thickness by which the center of the lens will rotate itself post-operatively. So we come to IOL power calculation in short eyes, that is axial length less than 22 millimeters. Studies have shown that the presence of short eyes, the predictive error within 0.5 diopters is much lower. So we need to be very careful while selecting the IOL power in short eyes, especially if the anterior chamber depth is less than 2.4 millimeters. In such situations, formulas taking preoperative ACD into account should be used, like Kane formula. Earlier, Haggis and Hoffer used to be used. Now the newer generation like Kane and EVO formula are considered to be more accurate. For longer eyes, formulas whose accuracy is not influenced by axial length should be preferred. In this study, it shows that the Barrett's formula is the most accurate formula for long axial lengths. This is a study comparing 11 intraocular lens formulas done in European Journal of Ophthalmology. It includes the newer generation formulas that we recently discussed and the third and fourth generation formulas. It shows that Barrett's 2 formula is most accurate for normal and long eyes, and Haggis and EVO is better for the short eyes. Thank you. So as we are short in time, I think we'll go on with the next speaker and we'll take the questions later. Next presentation. Okay. So I will be calling upon Dr. Palak. She's a cataract, cornea and refractive consultant in Nagpur at Arihant Eye Hospital, and she'll be presenting with her talk on IOL power calculations in different corneal conditions. Over to you.
Thank you, Hemali. Good morning, everyone. So today my topic is IOL power calculation in different corneal conditions. I belong to Nagpur from Arihant Netralaya. So the PPT would be covering the introduction that why there is a need for special consideration in such cases, the different corneal conditions which we deal every day, and what are the different consideration that we have to take while the calculation. So why there is need for special consideration in these cases is because the corneal shape here is not regular, and any irregularity in cornea induces irregular astigmatism plus myopia. After that, there is a wide range of K values in small area of cornea, and also there are changes in anterior chamber, which makes it more difficult to predict the effective lens position, on the basis of which many IOL formulas are based and they calculate the power. Also, the stability of cornea is a question in such conditions. Not only the ongoing disease, even the cataract surgery itself induces changes, and these cornea cannot resist deformation after the surgery. So these are different corneal conditions which we see on regular basis. So what are the main decision making points while calculating any IOL power? One is keratometry, that is corneal power, the axial power calculation, axial length calculation, the effective lens position prediction, and the formula that we are using to calculate, to put all these things together and then calculate a lens power. Of course, all of this comes after a thorough clinical examination for a particular case. Corneal astigmatism, as we talk, the regular corneal astigmatism is the most common condition that we encounter every day. So I'll just quickly run through this. The selection of patient for any toric IOL would be based on when there is regular astigmatism more than one diopter, and patient demands freedom from spectacles. In such cases, keratometry from any of these possible options is there, because the K readings in such conditions are repeatable and comparable. One important point in calculating toric IOL power is surgically induced astigmatism, because every incision on cornea gives some changes, and overall effect we can calculate by vector analysis. SI calculator is easily available online, and we can put our online data. I have written Dr. Hill, there is SI calculator on Barrett's site also. So this is how it looks, and if we fill data for some 15 to 20 patients, we can calculate our own surgically induced astigmatism, which is important while calculating toric IOLs. Now, IOL formula used, I think Barrett, all the lenses have their own calculators also, but Barrett toric calculator is most widely accepted and used and gives quite accurate results. This is how any calculation will look like. Now coming to the special corneal condition, that is corneal ectasia. Mainly here we are talking about keratoconus and post-keratorefractive surgery ectasias. Both of them induce progressive myopia and irregular astigmatism. For the point of discussion, both of them act very similarly, so we will be considering both them as one and will be talking further points. Now, while planning cataract surgery, it is very important that we document stability in these conditions. 2 to 3 corneal tomographies, 3 to 6 months apart, depending on the patient profile, should be documented, and a non-progression or halt of progression should be there. Also, it is important to keep an eye on progression post-surgery, because these cornea do not have enough strength to resist the deformation which happens after cataract surgery or any kind of surgery. Now, measuring corneal power is very important in such cases, which is also a challenge. Because as I already told, there is a wide range of change in K values in small area due to the corneal irregularity. Now, what is important here is to calculate the total corneal power. Now, most of the machines or devices which we are using actually calculates the anterior corneal power. It assumes the posterior by a fixed relationship between anterior and the posterior cornea, and that is how we get the power. But in such cases, that does not hold true, because there is no fixed relationship between anterior and posterior corneal surface. So all these keratometers, that is manual, automated, or even optical biometers or corneal topographies, do not give accurate results. The most accurate or the gold standard in such cases would be corneal tomography, which measures elevation in direct manner. So the most commonly used devices are Pentacam, Cirrus, and Galilei, which are based on Scheimpflug devices. So the problem which here we are facing is there is off-centered corneal apex. So such devices, we can actually choose whether we want pupil-centered K value or we want apex-centered map. So in such cases, these devices are useful, and we do not have to consider high K values from the apex, which is not actually in the visual axis. Now, there are two important maps which we get from these devices, is true net power and EKR map. So it is actually calculating both anterior and posterior surface cornea, and it is giving us these K values over different zones, that is from 1 mm to 7 mm. So we can select what type of K value, which K value we want to select, and according to the lens which we are putting, we can calculate. So this is how EKR map looks. So if you see, we have from 1 to 7 mm, actually 8 mm, all the K values. And we can choose whether we want the measurement centered at pupil or apex, and then the actual zone which we want to, I don't know if the cursor comes, here below we can actually put the zone which we want to select. Usually 4 to 4.5 zone K values are used to calculate IOL power in these cases. Also, another important thing is the EKR map, the power distribution in different zones which we see. So if in case we are planning toric IOL in such cases, it is important to see how the variation of K value is in 3 to 4 mm zone. If it is a huge variation, it is not ideal case to do toric IOL. Biometry, of course, optical biometry is superior to ultrasound biometry in such cases due to off-centered axis. Now the IOL formula which we have to use in such cases, there is no single best formula. It is different studies have shown different results. Mild cases have shown to have SRK2 formula to be good. In high myopia, SRK-T formula works better. If toric IOL is planned, then Barrett toric calculator. Holiday 2 formula is when ELP, we expect it to be quite variable, because this formula doesn't depend too much on that. And the newer generation formula, Barrett 2 and RBF, are into studies, but no one single study says that which formula could be best for these eyes. So I think case-based approach is required depending on what the myopia is, what the astigmatism is. We need to use these different formulas. Now coming to IOL selection in this cases, multifocal is a big no, because we do not want to induce any more higher aberrations. Already the eye has too many higher order aberrations. Yes, monofocal is the choice. Toric IOL, as I said, if the central 3 to 4 mm zone does not show too much variation in K values and shows regular astigmatism, we can think of it. But the important point here to be counsel to the patient is, this is just to debulk the astigmatism. It is not going to negate it 100%, and it is not going to cancel it at all. Now coming to other type of cases which we face is corneal transplant patients. It is extremely difficult to accurately predict corneal power in these patients. If a triple procedure is planned, the different methods that we can use is use standard K, that is 43.5 is taken as a standard value for these cases and IOL is calculated. Also, surgeon standard K can be calculated from the previous few surgeries. We can calculate what is the K power that we are getting, because mainly it depends upon the graft host junction and how we have used the tissue. Also, K value of the other eye can be used. Post-transplant IOL calculation, if we are planning, it is ideal to have all the sutures removed and astigmatism and cornea to be stabilized for 3 months and then do the calculation. So to summarize, all optical biometer is superior to ultrasound in such special cases. Newer generation formulas are better in calculation. Accurate determination of corneal power becomes very important for accurate IOL power calculation. ELP is usually variable in such cases, so do not depend too much on that. And promising patient independence from spectacle is actually unrealistic in such cases, because despite all the cautions and all the steps we have taken, we can always expect a refractive surprise post surgery, because there is no one fixed method, formula or machine which can bang on calculate IOL formula in such cases. What we can only do is try to be as close to the bull's eye that we say as possible. So a case-based approach is important in such cases, that after thorough clinical examination, after stabilization of cornea, putting the right values from the right kind of machine and then calculating it. Thank you. I would now invite the next speaker of our IC, Dr. Shreya Shah, who is going to speak on IOL power calculation in pediatric cases.
Thank you, Dr. Palak. Good morning, everyone. Today I will be talking about demystifying the lens power calculations in pediatric cataract. My name is Dr. Shreya Shah, and I'm a director and consultant at Rushabhai Hospital and Laser Center, Chembur. So pediatric cataracts do account for a large portion of preventable blindness amongst children. And unlike regular adult cataracts, there are a lot of challenges with pediatric cataracts, not just the technique of surgery, but a lot goes into planning it, a lot goes into working it up. So I'm just going to give a brief overview about the differences and how we can go about getting good results. So my presentation would be broken down into the following categories. Initially would be the overview of the anatomical considerations that differentiate adult and pediatric eyes. What are the challenges that are associated with calculating and planning the surgery? Biometry issues, the lens power calculations with respect to the formulae, targeting refraction, the choice of the lens used, and the summary. So anatomically, a pediatric eye is a lot different from an adult eye. It is shorter, the curvature is steeper, and the anterior chamber depth is much more shallower. As the child grows, as the infant grows, there is a rapid change in the measurements of the eye, which initially happen over the first 3 to 6 months, and thereafter it reduces. So broadly, the axial length initially at birth is around 16 to 17 millimeters. The K values are at 51.2, so it's very steep. And the lens power is around 34 diopters, which gradually reduces as the child grows. So the main challenge is, after any well-done pediatric cataract, barring all the surgical complications and the issues that may be there, is the refractive surprise that may occur. And this is extremely important, because this is what is going to determine what the child can see, and his or her visual rehabilitation is very important in how he grows ahead. So broadly, there are two types. A refractive surprise would be expected early on, which is immediately after surgery, which could be either because of biometry measurement errors, owing to the practical difficulty in acquiring the scans, the instrumentation issues, the choice of the IOL formula which is to be used to plan the cataract surgery.
and the refraction, the target refraction, which needs to be taken into consideration. And of course, a delayed change in refraction also occurs over a period of time as the child grows because of the myopic shift. This shift happens, which is very, very different, and it's based on a lot of factors. The amount of shift and the age has to be considered. The issues with acquiring an accurate biometry are a lot more in younger children, infants particularly, because the cooperation and fixation issues arise. So in these kids, we generally perform the biometry measurements under anesthesia, typically taken after induction, after putting a speculum. We try and ensure the corneal centration. K values are taken first, followed by the axial length and IOP measurements. IOP and retinoscopy also can be done. While taking the K values, the keratometry readings, a handheld keratometry is what is ideally used and should be preferred. We take an average of multiple measurements and average out the readings. Also, special attention to be made to rule out any kind of abnormal configuration such as microcornea or such. Sometimes in places where a handheld keratometry is not available, there are tables which give you age-adjusted values. However, this is not the ideal method to go about doing it. Axial length measurements are typically done using an ultrasound method, which can be either immersion or contact. Immersion methods are considered superior over contact because it doesn't cause indentation, and that is considered as the gold standard. Contact method gives you a slight underestimation compared to immersion values. These things also depend. However, sometimes because centration is a problem under sedation or anesthesia, the axial length measurements may not be very accurate, and a slight difference, even a 1 millimeter difference in axial length measurements, can amount to large errors in the final dioptric outcome. Ultrasound velocity is also something that needs to be considered because that may differ in kids because the vitreous is a lot more dense, presence of cataract, lot of factors. Lastly, optical biometry is also a great option, and it definitely can be considered in older children, typically around 3 to 4 years of age, above, depending on how cooperative they may be, and that definitely gives more accurate results. Now coming to the formulae. So IOL formulae are derived from data carried out in adults, and they cannot be used with great certainty in pediatric eyes. There are errors in measurement, the differences in biometry, the target refraction, the size, the shape, dimensions of the eye are very, very different. In short, pediatric eyes are not short adult eyes, so we can't, it's not safe to assume that adult regression formulae for short eyes, which would be your Hoffer-Q formulae, are advisable in eyes, children eyes. Also, there are multiple conflicting reports in literature as to, there are many, many studies which compare different IOL powers and the efficacy in pediatric eyes. However, there is not one power which is, one formula which is superior over the others or which has a great outcome. There are multiple formulae, like Dr. Himali earlier mentioned, the theoretical and regression formulae, which have been used over the last so many years. There is a slight evidence to suggest that theoretical formulae are not as accurate compared to regression. The unpredictable outcomes are pretty much equal with all the formulae, SRK, SRK2, Holiday, Hoffer-Q, SRK-T. So it's finally a surgeon preference, and you need to see on a case-to-case basis. Sometimes multiple calculations with all the formulae need to be done, and a target value needs to be taken. The variability is more in younger children under 2 years of age who have shorter eyes and steeper corneas. So there are factors which need to be considered when you're selecting the IOL power, typically the age, because the variability is more in infants, the status of the other eye, whether it's a unilateral or a bilateral cataract, the acuity at presentation, the refractive error, and the compliance of the child, because at the end of it, after the cataract surgery, it's not just the lens power that you're putting, you need to rehabilitate the child later. So these things are very important. There are two schools of thought which determine what the target refraction would be immediately post-surgery. So there are one school which says that an initial emetropia or a slight undercorrection is advisable. The advantage here is that there wouldn't be any amblyopia. The disadvantage is as the child grows and there is a myopic shift, it can result in significant amounts of myopia. However, it can be corrected later on as the child grows and becomes when the refraction stabilizes with refractive surgery. There is another school of thought which advocates the use of a high hyperopia. The advantage is that when the child is an adult, the refraction is stable or is plano. The disadvantage is that in this case, it can cause or even deteriorate the amblyopia. So there are multiple guidelines which determine the IOL power in pediatric eyes. There are multiple guidelines which have been put forth by many doctors earlier. Some of them for infants are as follows. So Dr. Wilson et al. Suggested targeting a moderate hyperopia in infants less than 6 months and a mild hyperopia in kids over 12 months. The infant aphakia treatment study also was a landmark study which also said that there's no significant difference in keeping the kids aphakic as opposed to primary IOL implantation, and that is the more preferred technique that is used now. And they also give recommendations as to the target of hyperopia that should be given. There are multiple guidelines for given by Dahan and Russo, by Chen et al. And Yeri, the rule of 7, which is typically followed, where the target hyperopia is 7 minus the age, and this is a very broad rule that can be used. Sometimes if it's a unilateral cataract, you need to take the other eye's refractive error into consideration and make sure that there is no significant anisometropia between the two eyes. The choice of IOL, PMMA acrylic hydrophilic lenses are generally not recommended because of the significant PCO formation and inflammation that they may induce. Acrylic hydrophobic lenses are the lens of choice, which can be either a single piece foldable or a 3-piece lens in the sulcus. You can also consider between monofocal and multifocal lenses, which I will discuss. Scleral fixated lenses, iris claw lenses, are reserved for special situations where there is inadequate PC support. Just to touch on the use of multifocal IOLs in children, this is an emerging concept, and it does have certain advantages in certain select cases. It does give you good distance and near visual acuity, improving the stereopsis. It prevents amblyopia because near vision is extremely important for a child's growth, and it precludes the use of bifocal glasses. So there are limitations as to where you can use it, but it can definitely be implanted in older children, in traumatic cataracts, basically in children who have had good vision at one time and you are certain that the eye is not amblyopic, so that helps. The limitation is the IOL power calculation, which is difficult to target because of the myopic shift that can happen and hence the predictability. So in this case, multifocality is not completely to achieve spectacle independence, but a thorough counseling can be done. Definitely it is something that can be considered in older children above 5-6 years of age. The glare halos decrease contrast sensitivity is a standard problem. However, with kids, their eyes are very, very adaptable, so they don't really complain much. And the other major limitation is that there is very limited data on the use, the efficacy, and the results, long-term results of multifocality in children. So to summarize, planning a pediatric surgery is as challenging as performing it. Pediatric eyes are not the same as short adult eyes, and that needs to be kept in mind when planning the surgery. Primary IOL implantation is the preferred method of going about the surgery, even in infants, and that is what is being advocated now, unless, of course, there are specific reasons why you would not want to put an IOL in the first place. We need to be very careful about measurements to avoid errors in the axial length and keratometry. Points that need to be kept in mind is that the IOL power calculation formulae, all of them have been derived from adults, and it needs to be worked on a case-to-case basis, and very careful selection needs to be done. General rule is to target hyperopia to avoid or counteract the myopic shift, and definitely there are more studies which are needed to achieve better results and get better outcomes. Thank you. I would like to invite the next speaker, Dr. Nikhil Balakrishnan, who's going to be talking about IOL power calculation in post-refractive surgery eyes.
So good morning, everyone. At the onset, I would like to thank Dr. Himali Kapania for giving me this platform to speak today. My topic today is IOL power calculation in post-refractive surgery eyes. I have no financial interests. So a lot of people in the earlier generations who've undergone kinds of refractive surgery are today coming to us for cataract surgery. So the challenge in this is finding the right IOL power for them. So what are the different errors that happen during IOL power calculation in patients who've already undergone refractive surgery? The first is the keratometric error. So what that means is that in patients who have undergone a myopic LASIK, there is usually a central flattening as compared to patients in hyperopic LASIK who have a central steepening. In both these conditions, there is an altered anterior to posterior corneal ratio. Second is the formula error. A formula error is that the formula usually takes into consideration the corneal power, the anterior chamber depth to predict the effective lens position. Already as we've discussed, in both in LASIK, the corneal power is altered and hence the effective lens position is also not calculated properly. So what happens is in myopic LASIK, it predicts a shallow ACD, hence an anterior ELP is considered. There is an underestimation of the IOL power and you end up with a hyperopic surprise. In a hyperopic LASIK, it predicts a deeper ACD, a posterior ELP, and there's an overestimation of the IOL power causing a myopic surprise. Coming to the next thing is the instrument error. So the instruments usually get you the data of the central corneal curvature by procuring the paracentral measurements. So here, as the paracentral areas are altered as compared to central, you get wrong readings. In post-RK eyes, usually you have a smaller optical zone. Hence, it is necessary to take corneal readings on the central 3 millimeters. Also, there is a lot of irregular astigmatism post-RK, and hence you get a difficulty in determining the true corneal refractive power. In cases post-smile, there is a steeper central 2 millimeters of the anterior cornea, and the periphery is usually more flatter. Usually in this case, the asphericity of the cornea is well maintained, so that is not a challenge in cases post-smile. And usually there are good agreements between the ray tracing and the 7 formulas in the ASCRS calculator. So smile patients who've undergone smile are usually not that much of a challenge calculating the IOL power. Now, how do we overcome these problems? It's important to choose the right formula. So usually you have an ASCRS online calculator to calculate the post-refractive surgery formulas. This is freely available on the ASCRS or the APACRS website. You there have to choose between which procedure has the patient undergone first, being myopic, hyperopic LASIK, or an RK. This is how the calculation sheet looks like. You need to put a target refraction, which is usually 0 for post-LASIK and smile eyes, -1 in case of a post-RK, which is 16 cut, and -2 with a post-RK 32 cut. If you have the pre-LASIK data, it's very important to enter that also. Post-refractive surgery data should be entered only if you have it immediately post-LASIK, not the current data, because the current data would include the changes which have been occurred due to the cataract occurring right now also. If you have the topography values from any of your topographers, you need to enter it here. The different topographers mentioned here, you can enter it accordingly. And finally, the biometric values from your optical biometer need to be entered into this area. Following this, you get if you've entered the pre-LASIK data, the formulas on the left, and if the pre-LASIK data has not been used, then the formulas on the right. It usually averages it all out, and you could choose the IOL power formula accordingly. Now, choosing the right IOL, it's important to use your demons to your advantage. Usually in all these refractive surgeries, a lot of abrasions are induced. So what you need to do is target a 0 spherical abrasion so that the visual quality is improved too. So we all know that usually the cornea is usually prolate. It has a Q value of -0.26. In a post-myopic LASIK, the cornea becomes oblate. It's a positive Q value here. So it is necessary to implant an aspheric IOL with a negative spherical ablation. In a post-hyperopic LASIK, the cornea becomes more prolate, the Q value is more negative, and hence it is important to implant an IOL with a positive spherical abrasions. And finally, in post-RK or in cases of decentered ablations, in both of them, it's better to implant an IOL with 0 spherical abrasions because the cornea is already in a pretty bad shape. So this is a list of different IOLs based on their asphericity and, as I spoke, which ones to select. So here you not only get the perfect quantity but the perfect quality of vision too by taking into role the spherical abrasions. Now, would you do most of these patients are the ones who wanted spectacle independence, and that's why they've undergone a refractive procedure. So can you put an MFIOL post the procedure? There are a lot of papers right now well published saying that multifocals may be implanted post LASIK and other types of refractive surgery too. I'll just run through two different case examples. Here you have a lot of higher order abrasions. If you see, this is not an ideal case for an MFIOL to be implanted. As compared to somewhere where the cornea is more regular, the higher order abrasions are much more minimal. So in this case, you can go ahead and implant an MFIOL. So MFIOL is not a complete no-no. Looking at the case, studying the cornea, you can decide whether to go ahead and implant it. And finally, coming for in cases of decentered ablations, it is better if you first undergo a retreatment, center the ablation, and then proceed with cataract surgery so that you get your IOL power calculations correct. Thank you. I would now like to invite on stage Dr. Ashish Ahuja, who's going to talk on corneal IOL powers in refractive surgery, in post-retinal disease.
Good morning, everyone. I'm Dr. Ashish Ahuja. I'm a vitreoretina surgeon. I'll be discussing about intraocular power calculation in patients with retinal pathologies. So, the journey for intraocular lens implantation started with Sir Harold Ridley in the year 1949-1950 when he implanted two patients with an intraocular lens, and he had a 21 diopter surprise in his first two cases. So the journey for accuracy in calculating lens power started since then. So performing cataract surgery without retinal evaluation is like shooting blindfolded and would result in having unhappy patients. So let us discuss some clinical pearls. Pre-op counseling is the key for operating on patients with retinal pathologies, and a guarded visual prognosis should be explained. We have to give a realistic expectation. Patients may have an ERM or a vitreomacular traction which can cause distortion. So this has to be detected and counseled appropriately. Sometimes we'll have an isometropia with unequal axial lens or a unilateral high myope, which would be known amblyop since childhood. So these things should be counseled preoperatively. In case of a previous retinal surgery, patients will have a pre-existing posterior capsular rupture or a primary PCO would be there. So the decision for cataract surgery alone or combined with vitrectomy needs to be taken on case-to-case basis. In patients presenting with a retinal detachment with a complicated cataract, the other eye biometry can be taken into consideration. Always we should go for a monofocal IOL in patients with retinal and macular pathologies. Nowadays, swept source OCT based biometers are ideal and giving us more accuracy in calculating IOL power. Key to note in patients in whom a scleral band or a 360-degree encirclage has been done, it will lead to an axial length elongation, so that fact also needs to be factored in. Preoperative OCT macula should ideally be done in all cases, but if not, at least in premium IOL cases and in patients in whom vision is not corresponding with the cataract. Axial length measurement errors can occur in patients having staphylomas, in patients having macular pathologies where they are not able to fixate, and in patients having RD or choroidal detachments. Nowadays, swept source OCT is available, and in the IOL Master 700, they also provide a macular map. A macular OCT B scan is available, so the clinicians or the optometrists can also pick up, if there is a pathology or things are abnormal. So the speed of ultrasound varies based on the different media. So this has to be taken into consideration. Considering that 80% of the eyes do develop cataract in if they are undergoing vitrectomy, so a combined procedure is being considered nowadays, especially in patients above the age of 40. So there was a study which was done which noted that the Kane formula was giving good results in patient undergoing combined cataract with vitrectomy. In olden days, earlier we used to use a correction factor of 0.71 in eyes which have silicone oil for accurate IOL power calculation, but nowadays even the optical biometers are giving good and accurate result, because the silicone oil will give a variable speed of ultrasound which could result in false IOL power calculation. So this was a study which was done in calculating the refractive outcomes in patients with cataract and silicone oil removal. This was a prospective study which noted that Haigis, Hofecu, Holaday 1, 2 formulas were comparable in patients having normal axial length eyes, but SRKT and Haigis had an advantage over other formulas in longer axial length eyes containing silicone oil. So error in IL power calculation is known to happen in patient having staphyloma because the fovea may not be located at the deepest point of the staphyloma. So the anatomical axial length may not be equal to the visual axis, the visual axial length. So that error could happen because most often the fovea would lie somewhere else on the slope inside the staphyloma. So that has to be taken into consideration. So this is an image showing the B scan and the regular A scan which has been done, which is showing an error in the axial length calculation by 0.73 millimeters, which can result in a 1.75 diopter surprise post-op. So let's evaluate thoroughly and keep our patients happy, and let's hit the bullseye. With that, we'll end our IC. Thank you for your time.